Good afternoon, everyone. Welcome to the fifth session of the Commission and ANA's fifth Racism in Nursing series. Whether you have been involved in previous series or are new to this space, we are so excited to be back, and we hope that this interactive learning space is a place for you to find guidance and support. Today's session is one of an 8-part series. You will be able to earn 1.5 continuing nursing education units for attending today's session. Please stay to the end to complete your evaluation and receive the CNE certificate. This series is brought to you by the American Nurses Association and the National Commission to Address Racism in Nursing, a multi-organizational collaborative of leading nursing organizations examining the issue of racism within nursing and motivating all nurses to confront systemic racism. The Commission and ANA remain committed to driving systemic change within the profession. The association's recent response to executive orders affecting diversity, equity, and inclusion underscores its dedication to advocating for inclusive policies and combating structural inequities in nursing. ANA continues to work with Congress and federal agencies to mitigate the impact of policies that threaten progress in health equity and workforce diversity. Please scan the QR code to learn more about ANA's public statement, Protecting Healthcare for Americans. Before we get started, let's review the ground rules for each of our sessions. Please remember that this is a brave space. Discussing racism and health equity is difficult and uncomfortable, especially for those directly impacted. Discussions such as these can serve as a trigger. We ask that you maintain respect for everyone joining us today. Please stay on mute until it is your turn to speak. Listen intently and respond thoughtfully. Be present. Limit background distractions and multitasking. Please do take advantage of the virtual features available via Zoom. We encourage turning your cameras on and using the chat box if you are able, or the raise your hand feature to communicate with the group, but please remember to mute your microphone when others are speaking. Respect participant privacy. Do not disclose names or other sensitive information shared. If you share a scenario involving a patient, do not provide any PHI during today's call or any of our sessions. Because of what we are trying to achieve with this education session and the desire for a brave space, ANA reserves the right to remove anyone who, in our judgment, is not adhering to these ground rules. Please do note that the chat will be closed during the speaker's presentation, but it will be turned back on during the breakout sessions and in the larger group at the end of today's session. Today, promoting equity and justice through anti-racist nursing policy. This session will be presented by Cheryl Peterson and a panel of experts, Dr. Cami Daniello, Kim Kim, and Dr. Monica McLemore. I will now turn this presentation over to them.
Thank you. And really appreciate everyone being with us today. I'm Cheryl Peterson, the Senior Vice President at the American Nurses Association. And we are here to talk about policy and how policy either moves forward us toward a more anti-racist place, profession, laws, rules, or how they may hinder our movement toward a more anti-racist place. Next slide, please. I worked with the team who drafted the policy report that is in the commission's larger report. And we looked at the term policy there, and then we looked at the foundational documents. Well, this one is, no, it's been since. The foundational documents about how nurses are or should or could show up in this space. And we are called to address unjust systems and structures and to use our voices to advocate for transformative action-oriented policies and initiatives that mitigate inequality and promote social justice. This is part of the foundational work that we are called to do as nurses. Next slide. Even more, when we look at our code of ethics for nurses, which was just revised, I hope everybody has it, has read it. It's a critical document. Our provision 9 calls on nurses and professional organizations to work to enact and resource practices, policies, and legislation to promote social justice, eliminate health inequities, and facilitate human flourishing. So again, this is part of who we are as individuals, as systems, organizations, and as a profession. Next slide, please. But we live in very interesting times now. And there is much that feels very chaotic. There are policies that some would agree with, some don't, but how they're being initiated is very challenging for us. So we are not having this discussion today in any kind of vacuum around what is going on in our broader environmental context. Next slide. Oh, sorry. All right, now we're going to move. Those are just a few opening remarks from me, but I really want to get to our panel because we have an incredibly smart group of folks here. And if my panelists don't mind, I'm just going to refer to you as Monica, Kim, and Cami, just for ease. And, you know, I appreciate everyone who has achieved really great things in that education space. But if you don't mind, we'll go there. So Monica, I want to start with you to give a little bit of an opening statement that you might have.
Hello, everyone, and I'm really grateful to be here with you all, especially in light of the fact that we are preparing for National Nurses Week, which we observe on the anniversary of Florence Nightingale's birthday on May 12th. I personally want to welcome everybody to be here. And frankly, I also want to acknowledge that this is the year anniversary of everybody's work. You'll see my background is from the film. And if you've had an opportunity to see it, then you know how seriously we take the work of nursing and dismantling racism from the inside out. I would like to just remind everybody on this call of some very important things that I think we know intuitively as nurses, but I just want to name specifically. And the first is everything that we're currently experiencing is temporary and thus mutable. And I think if we have the courage to be able to act, that we can change it. And policy is just one tool that we can use. And number two, that the brilliance and the visionary leadership that is currently needed exists in nursing. And I hope we can have that dialogue to activate our profession so that we can really step up and lead. I appreciate being here today, and I'm looking forward to conversing with the other panelists.
Thank you, Monica. And I think, Cami, you had something you'd like to say as well. Go ahead.
Yes, thank you. I would also just like to thank both ANA and the National Commission to Address Racism in Nursing for acknowledging our past history of oppression as nurses and for the ongoing work addressing racism and providing tools to have these necessary and difficult conversations. Items like this and the other efforts that the commission has had over the past couple of years, I think have helped to elevate the discussion and also broaden it across the profession. And I really appreciate that. Thank you.
Thank you, Cami. And now we're going to roll up our sleeves and really dive into policy, right? The word policy, it means different things to different people. Policies made by others impact every aspect of our lives from the very local through the state to national, organizational, international bodies, and policymakers. So my question to each of you, and I think, Kim, we're going to start with you, and then Monica, we'll head over to you, and then Cami. What does policy mean to you?
Thank you, Cheryl. So I would also like to extend my gratitude to the Commission and ANA for the invitation to be on the panel. And I am currently a student, so I think my lens is a little bit different because of my enrollment status. I've been a faculty in the past, I've been an undergraduate, I've been a graduate student, and I'm a postgraduate student. So policy means many things, but what always comes up for me is looking at the framing of it with past, present, and future. So I really appreciate in the report how we did get accounts of harm that have occurred and policies that have shaped that through the structural nature of nursing and how it was set up. But I also want to bring it back to the present and the current harm. So I think of the nurses in the clinical setting, students in academic settings who are currently being harmed by policies that need to be revised and are not meeting the needs, and then go from there to build how are we going to change this, because it was not designed for it to operate in a way in which we wanted to. And so that restructuring really needs to happen. And I think using those three viewpoints are what stand out for me.
Yeah, terrific. Thank you, Kim. Monica.
Well, I think about policy, big P, small p, right? So big P policy, if you're thinking about federal or, worldwide, if we think about the International Council of Nursing or we think about the World Health Organization, like that's a big P policy, right? What are the large structural mandates that dictate behavior or activities that can improve human health? And as a researcher, I think about big P policy, and I spend a lot of time doing that right now because of our current environment, because a lot of people don't understand or appreciate big P policy. Like, it is amazing to me that folks don't understand the implication of either, tariffs or Medicaid or whatever. They don't understand how policy even works and impacts their everyday life. This is why I think nursing is key to helping us to move through this current moment, because we know that language and we can be able to translate that for the public. But then we have small p, right? We have small p policies that I think a lot of times in nursing, we have really worked really hard to make sure that policy is informed by science, that it is evidence-based, so that we can make sure that it's not just an institutional thing. Oh, at my hospital, we're going to do this, and at this hospital, we're going to do that. No, there's a standardization and language that needs to be utilized across institutions and across different geographic locations so that we can set a baseline that's standard. That's why we have clinical practice guidelines. In my mind, those are policies, right?
Yeah.
So for me, I make a distinction between small policy, which is where the rubber hits the road, and then big policy, these larger sort of structural pieces that impact how we do our work and health outcomes.
Great. Cami, what's up with you?
Always trying to find the unmute button. Really, Monica, I really appreciate you distinguishing between the big P and the little p, because policies sometimes are interpreted as policies are bad, and policies in and of themselves are not inherently bad. They help to guide us and guide our programs, and they're used to help us make decisions, whether that's at the small p organizational level or the big P governmental level. What we need to be asking ourselves is, how does racism show up within the sphere of policy development and implementation? As an association leader, what I look at is, when I'm developing policies or looking at them, how does this perpetuate racism in nursing? If we ask that of ourselves every time we look at trying to put a framework around something, whether it's how you collect dues, whether it's how you implement standards of practice, it's really about, how does it perpetuate racism in nursing? What are the potential unintended consequences? And I think one of the other big challenges with policy is, in defining it, is, has there been agreement and involvement with your stakeholders? It doesn't help if policies are made, and we've all talked and heard about top-down policies coming from administration. Well, it's got to include those who the policies are affecting. And if they're reactionary to deal with a particular situation, it may not be doing that. So we really need to start thinking about it. How does this policy, how does this action affect racism in nursing?
You know, it's interesting listening to you because, right, we can write, there's a policy that's on our walls at our institutions, right? Is that we don't discriminate, we value everybody, right? But actually, when you get into the implementation, there is this implementation, but then there are these unknown pieces that you don't know are the barriers. And I think, Kim, you're talking about education. I think there's some of that that goes on. There's these unknown rules that all of a sudden you stumble upon and you don't even know that they exist. So really appreciate all those insights. So let's go on. In the commission's report on policy, it stated that racism is perpetuated through the systemic and structural nature of policy. It's a given. Do you agree with this premise? Can you give an example of such a policy? And how might you begin to unravel that wiring? So, Monica, I'm going to start with you, and then I'm going to go to Cammie, and then I'm going to go to Kim.
Awesome. Well, this is really hard. I think a lot of times for nurses to understand that how policies inherently that may seem universal are actually structurally racist. So I'm gonna name like 3 or 4, but then I'm only gonna do a deep dive on one, right? Just to give you a sense of how this functions. So like as a country, the fact that we don't have paid family leave or postpartum coverage, in my mind, that's a structural racism problem. And I can go into that for a long time. Carceral health and the loss of Medicaid prior to incarceration, like that is a whole other conversation that I might want to use, but I'm not going to use that as an exemplar. Or the fact that we use the disability system for pregnancy leave. We just don't have a leave for pregnancy. Like that was negotiated, and that was a retrofit with the employers, and right. So there are so many different, but let me get at the heart of something that I think nurses universally can get at that they may not necessarily see as an inherently racist, structurally racist policy, but it really is. And that's employer-sponsored health insurance, right? In our country, you have public insurance, which we call Medicare or Medicaid, and that's based on either disability or age or whatever. We have all these conditions. We can't just insure people, right? Employer-sponsored health insurance is problematic for a whole variety of reasons. Number one, we know that minoritized communities are most likely to be underemployed. And so if your employment is tied to, or your health insurance is tied to your employment, you're probably going to have poor health insurance or not be eligible for it. Or when you have income requirements around employer-sponsored health insurance. Well, if you are working minimum wage jobs and a minimum, like it's all crazy, right? Or when you think about religiously affiliated employers, whether you share that religion or not, you are subject then to the services that only they will offer you based on their own provision. So employer-sponsored health insurance in and of itself is a problem. And that under the Patient Protection Affordable Care Act, one of the reasons why we wanted to give more pathways to insurance is because as nurses, it should be very obvious to you that insurance is one of the #1 interventions we can do to improve human health. Because then you take the cost piece out of it, you take the access piece out of it in some places, right? So this idea that it's a structure, why do we put insurance on employers when there are other payment models, other players, philanthropy, for-profit business, like there's a whole variety of other ways and government funders where we could have come up with a better way to cover as many people as possible when we know that insurance is one of the #1 ways to be able to prevent illness, death, and disease in individuals. So in my mind, structurally, the way we think about how we cover people, we can do that better and differently. But that requires having a philosophical orientation that everybody deserves coverage and not conditional coverage.
Cammie?
Thank you. I think one of the best examples that comes to mind that I think we can relate to very easily as nurses is the hiring practices about 10 years ago, which swung toward favoring baccalaureate degree prepared nurses as entry into practice. There was some research that was published that was very widely looked at that said if you have a higher percentage of nurses with bachelor's degrees, you have lower morbidity and mortality rates. So those hiring practices, oh, we're going to hire nurses with have BSNs or higher, were evidence-based, but we didn't really think about the impact that had on the diversity of our profession. The RN, the BS only paradigm really didn't assist us because we were looking at, where are nurses of color coming from? A lot of them are coming through the community college system. They're more likely to attend those community colleges. They're less likely to be accepted into baccalaureate programs. And my research has shown that it's more challenging for them in baccalaureate programs. There's a lot of racism amongst the nursing faculty. And so, there also wasn't research that looked at, is it the entry level baccalaureate degree that reduces morbidity and mortality? Or is it somebody who has now had a liberal arts exposure and achieved a BSN, whether it's an RN to BSN or they had a BSN in something else prior to entering the profession and they pursued an associate's degree? What do those nurses have? What's that effect on morbidity and mortality rates? So even though it was a policy with good intentions based on what the evidence was at the time, the consequences were that we ended up with a less diverse profession, more challenges for nurses to be hired who had the experience level and the education. And it really did not, it lends back to what I said before about, what are those unintended consequences of our policies? Did we examine it for the effect it could have in perpetuating racism?
Thank you. Kim?
Yes, thank you. So to piggyback off of Cammie's topic, I'm not going to delve into this one. I have three and one that I'm going to spend more time on, but magnet status is what I was thinking about, Cammie, while you were speaking. So we know that we have set benchmarks and accreditation and such that designates us as specific levels within the profession or patient outcomes and things of that nature, but it's inherently racist and it's a hard conversation. So I think that could take up more than an hour, and this is a safe space, so we have to have hard truths. But that's what I was thinking of, Cammie, when you're speaking. So another one that I won't get into very much is just simple policies within the hospital. So when I worked bedside, I'm from a Latino background, and this policy about how many people can be at the bedside when a loved one is going through the end of life, that it does not meet our cultural needs. And so some of the policies that exist are looking at one demographic and what is considered normal and appropriate visitation. But the one that I really want to highlight is related to the academic setting and what professionalism looks like. So as a prior faculty, I was in charge of clinical placements and had the privilege of speaking with students on a regular basis. And students, male and female and non-binary, with textured hair are often harassed about their hair. Point blank are harassed. And so our policies are inherently racist because we're asking the students to ascribe to a look that just naturally does not grow out of their hair, and also is perpetuating and upholding this image of a nurse to look a particular way, often as a white female would have in contemporary times. And that's not who all people are when they show up for clinical. Some of the other things that we get into, the nitty gritty, are about like earrings being pierced and, ankles showing and things that were like, what are we really talking about? When you ask patients how they feel about nurses who care for them, they remember how the person made them feel, not if they had a tattoo on their forearm or if they had small hoop earrings, whether they had a hijab on their head or whether they had their hair in braids or twists. So it just, there's a lot to dissect there. And I think that we need to do a better job when we're having these policies about thinking about, as was said earlier, who's at the table when the policies are being made, because if the folks who are being targeted are not there to help people realize that that's not their reality, we're missing things. And this is something that comes up over and over and over again, especially with the viewing of everybody's work. I've had numerous students come forward not having a place to go to raise these concerns, not feeling that they could because of the power dynamics that are in place. So I really think we need to look at that in the clinical setting when students are being sent out, and also when they're on campus, because we really have some rigidity around what the image of nursing is.
Thank you. Thank you. So much to think about. And I'm going to shift up and move to a different question that I think feeds a little bit into what we've been talking about. But there are many adages out there along the lines of, we need to have a seat at the policy-making table. If you aren't at the table, you're on the menu, you're on the lunch table. Or if you don't have a seat at the table, pull up a chair and sit at the table. These all speak to the need for nurses to be part of the policymaking process at all levels and across the whole spectrum of policymaking bodies. Can you speak to a policymaking table that you are at, how you got there, and how might others engage in these places where decisions and policies are being made? And Cammie, you get to kick us off.
Thank you. You know, for me personally, engaging in policy development means that we need to make sure that all the stakeholders are at the table. And if we're at the table and we're not seeing people that are missing, we need to bring that up and make sure they get there. We need to have the right voices and subject matter experts together at a collective level if we're going to affect change. You know, from in Massachusetts, which is where I'm from, and where I'm more heavily involved in the policy arena, you know, it's things like making sure there is a RN on the board of the Health Policy Commission, which helps set the policy agenda for the Commonwealth, deals with rate plans, et cetera. There was no nurse on the Health Policy Commission. It was physicians, there was SEIU, there were representatives from insurance there, but there was not a registered nurse. So as part of an organizational effort, we ended up ensuring that there's an RN on the Health Policy Commission, and it has made a difference in their actions when they start talking about maternal morbidity and hiring doulas. It's the nurse's voice that's coming through there, not the physician voice. You know, our current policy advocacy work is we're looking to ensure that there's an RN on the governing board of every acute care institution in the Commonwealth, as well as the board of every nursing home. We're not specifying who that RN has to be, but you know, we need to ensure that nurses are there and at the table. And if we have to legislate it, then we have to legislate it, because you know, if you look now at the number of RNs that are serving on, does every hospital board have a registered nurse on it? And I'm not talking the administrative piece where the CNO is. We're talking the decision makers about strategy. There should be an RN on every single hospital board. There should be an RN in every nursing home on that board of directors, particularly the for-profit ones.
Yeah, thank you, Cammie. Kim.
So for me, I haven't always had an invitation to sit at tables, and sometimes I've just had to make my own rather than try to fit in where I'm not wanted or valued. But something that I just want to plant a seed of is in the actionable allyship lane. So as a faculty member, as I heard so many concerns raised from students and them feeling like they weren't being heard, what you created the table to be was helping the students gather and develop a diversity task force. And so in that position, I used my allyship to provide the power to the students, who then drove what we would talk about, what we wanted as outcomes. And I really just reserved the room and was there and listened. So sometimes I think when we're looking at using the seat at the table, if I'm not the person being harmed, that doesn't mean that I cannot help bring in those voices that need to be heard directly rather than me speaking for them. When we had the task force, there was really nothing in place to provide a voice for students to share concerns, feedback, but also the students, like we've heard before, the stakeholders have a lot of insight. And so the students were able to come up with many examples of how course objectives and course assignments and clinical experiences could be adapted to increase anti-racism, also anti-bias discussions. And so I think that for some of us, when we're looking at getting a seat, if we're invited or whether we make our own, is, whose voice needs to be heard. And sometimes getting the seat for me is ensuring that the people that I need to help elevate the voice for, I'm getting them in that space.
Yeah. Thank you. Monica.
So here's where I'm gonna be controversial, because I think it's really important that the almost 600 people on this call really understand this. For too long in nursing, we have left policy tables and policy seats and the designation of those to our professional organizations. Now, I get the irony of being on a policy webinar with a professional organization. And I no hate to A&A, because whether it's A1 or ONS or all the acronyms that we have, I mean, we actually have a body, the Academy of Nursing, that is supposed to be the policy voice for our entire profession, right? So on the one hand, for those who don't know that, historically, that has been an effective way to do things, but that's not the only way to do things to get at tables, right? If you're not participating in your professional organization, not going to the lobby day, how do you even know how to learn how to exist in a policy space or what that should look like? So I'm not advocating that we get rid of that. I just think that there are other ways to do this. Why did I join the Black Mamas Matter Alliance? I've already heard maternal morbidity and mortality, because we were over premature Black death and preventable deaths of people. So we had to create our own table. We went to representatives who cared about this issue, Rep. Alma Adams and Rep. Lauren Underwood, who is a nurse, by the way, in Congress. We went to them and explained, hey, we care about this. We want to do advocacy. We want to do education. We want to include evidence in bills, right? But here's the other unpopular thing about us as a discipline and profession. We're going to address racism in nursing. And if we're going to address racism more broadly in our society and in our world, legislation cannot be the only path. Creating laws, expecting Congress and Senate to do their job, whether at the state or the local or the federal level, legislation is really important, but we cannot forget about litigation, right? Sometimes we need to sue people when things are not right or when the law has been broken. And we as experts need to be able to inform what that legal strategy looks like. I am tired of us begging Congress, begging the Senate to give us the money we need to educate the future workforce, to deal with the shortages, right? At some point, we are going to really need to think about maybe suing hedge funds who are buying up hospitals and consolidations, to be able to say that this is incongruent with our code of ethics, and that we really need to be able to sue on behalf of patients to get the care that they deserve, right? That is a different tool of policy besides legislation. It is a skill that can be built, and it's one that I really think we need to think about, as we move forward in our current environment.
Yeah, and Monica, you went where I'm going to go next, right? There are national nursing organizations. We have state nurses associations. We have ethnic and minority nurse organizations out there. We have national nursing organizations in education. And so if you could, as you think about this kind of broad array, if you had something to say to the leaders of those organizations around policy, I'm inviting you to say, what would you say? Kim, we're going to go to you. So you're on the hot seat first, then Cammie. And Monica,
Okay.
I'm going to let you kind of take us out. Now, we only have 2 minutes, so I need you all
I'll
to
be quick.
be quick so that we can get to our small group work. But
Yeah.
Kim, go ahead.
Sure. So I'll preface by saying this is my opinion. I don't represent any organization I've had affiliation with, but I have had to make decisions about where I'm spending money to remain a member this year in particular, because we can't forget when we're part of affinity groups that for those of us in a particular ethnic group or racialized group, if the community is experiencing something, we're experiencing it too, and we can't separate those two. So if we're going to focus on what the community needs, but you're not holding any space for your members to talk about what they're going through with being targeted in particular settings and, you know, being demonized in the media for being criminals and such, and you're saying nothing to check in about like, how are you doing as our member? I can no longer support with my funds because I also have to survive in order to help my community. So I would advise people who are in leadership roles to be bold. And I would love to shout out Dr. Sheldon Fields because he doesn't mince words. And I'll also like to shout out Dr. Danielle McCamey. I'm a proud student member of DNPs of Color because she pulls us in and is like, let's talk. How is everybody doing? Because I can't do my service if my cup is empty because I'm also experiencing those difficulties.
Yeah, thank you. Thank you for that. Cami.
You know, I think as a profession, we need to go beyond developing policies. We need to really have effective leaders who are committed to incorporating all the voices in defining racism and that have the courage to act.
Yeah.
Our commitment and our abilities to work in concert with each other as organizations makes us stronger. The ability to work with, you know, as the National Commission did, which brought together a number of organizations to highlight the efforts and really bring that discussion forward, I think is one of our strengths as a collective. And I think we all need to have that little bit of courage inside of us sometimes to speak out.
Thank you. Monica, bring us home.
I'm gonna make this real quick because I could talk about this forever. Sigma, ICN, ANA, AAN, AACN, all of our organizations need a collective statement, a collective strategy, and a collective action.
Yeah.
And I've been heartened to see some partnerships around certain issues, but we need to stand on who we are as nurses. We need to commit to nursing the nation. And we need to recommit to dealing with the fundamental problem here, which is structural racism across not just healthcare, but just across our world. And if we decided that we wanted to do that and stand arm in arm with each other to be able to figure out how to do that, I think we could be very effective, but we all have to do it. We need a collective statement and action.
Great. Thank you. Thank you, Kim, Cami, Monica. As always, whenever I have a chance to hear you speak, I learn something new, and I say thank you to all of you for your leadership. I believe now I turn it over to Kara to take us into our small groups. Thank you. Thank you, panel. Really appreciate you.
Yes, thank you all so much. Sarah will pop us into our breakout rooms for about 25 minutes and we'll come back to the larger group.
Just a note to remember which room number you are in case you get kicked out and come back to the main room. I can put you back in that specific room. Here we go.